The patient is assigned a stage of disease at diagnosis. And 20 years later, the patient is alive and free of disease, but in the cancer registry, he still is considered stage 3 term cancer. So that is archaic. The system cannot be static, it has to move along with the patient's life and be dynamic. And finally, the current system does not include response to therapy because that is an important prognostic factor which should enter into any dynamic staging system. In the last edition, 8th edition of revision of the staging system, the goals were to have global applicability, but it would have to be a compromise between a highly accurate and complex system with low compliance and a relatively simple system with high compliance. So it is a difficult job to arrive at a staging system which would have high compliance and improved accuracy. The 8th edition was published in 2016 and is currently still in practice, while the 9th edition is being produced stepwise with each primary site on an individual basis. This morning I'll confine my remarks for the 8th edition revision only to the oral cavity tumors, although changes were made into oropharynx, thyroid, skin, and nasopharynx. The progress made in the 8th edition involves the addition of external staging, which would upgrade the end stage to N3. And in the primary tumor, depth of invasion was added for more accurate assessment of the risk of nodal metastasis. So ENE, extranodal extension, would upstage the tumor regardless of the size of the lymph node. It may be even less than 3 centimeters. But if it has extranodal extension, it would be upstaged to N3B. And here is the detailed nodal staging, which is readily available on the internet. But suffice it to state that extranodal extension upstages the tumor to N3B. For the primary tumor, the third dimension was added. We were up until then, we were only measuring the tumor on the surface, the length and the width, but now the depth is added in 5 millimeter increments, 0 to 5, 5 to 10, and over 10 millimeters. So that has entered into the T staging for oral cancers, and clinically, clearly you cannot accurately assess the depth of invasion. So clinically, the tumors are divided into thin tumors less than 5 millimeters in diameter, approximately, thick tumors between 5 to 10 millimeters by bimanual palpation, and very thick tumors which would be over 10 millimeters. Clearly, there is a margin of error in clinical examination. But the depth of invasion will clearly upstage the tumor regardless of the surface dimensions of the tumor in T staging. In future, we want to add to this TNM staging system histomorphological features, molecular markers, non-anatomic prognostic factors, socio-economic status, lifestyle, and comorbidities, as well as response to therapy. And therefore, the goal is to develop a dynamic, personalized prognostic nomograms. In other words, the staging for each patient would be different on the nomogram. It would not be a group staging for all patients with similar extent of disease. So the rationale is that any single risk factor taken in isolation leads to decrease in predictive accuracy. Conversely, a prediction model that considers multiple variables is more accurate than a simple risk classification. The prediction model takes into account tumor variables and allows the clinician to make a rational decision for treatment based on estimated risk. And it also empowers the patient to understand the implications of their decision in terms of the benefits and risks of treatment offered to them. So what is a nomogram? Nomogram is basically a line chart which shows scales of variables involved in a particular formula in such a way then corresponding values for each variable lies in a straight line across all scales. So, for example, here is a nomogram which takes into height, weight, a patient's body weight, body mass index, etc. So here is an example. A modern medical nomogram is a statistical prognostic model which is available on a graphical hard copy and is also available on a computer or on your smartphone, iPhone in your hand, where you can in an instant arrive at a nomogram while the patient is sitting in front of you as you enter the various parameters that are important for the patient's prognosis. So, nomogram, for example, maps a patient's age, primary site, age dimensions, clinical nodal status, comorbidities, tobacco use, patient's ethnic race, etc. And each of these parameters is given a point score based on its impact on outcome on an individual statistical analysis. Take, for example, here is a patient with a 3 centimeter tumor with a clinically positive lymph node. So the 3 centimeter tumor is shown in here red, giving 70 points. The lymph node metastasis gives 30 points. The subsite of the tongue does not make a difference. There is no bone invasion, so there are 0 points for that. When you add up all these points, it comes to 130 points, giving you a 30% probability of mortality from this cancer. Now remember, this is beyond TNI. There are other factors added to that. And the advantage of this is something I will share with you. It has the ability to estimate individualized risk for each patient. It is user-friendly. It incorporates continuous variables, and it is better than clinician's judgment. There are numerous nomograms already available in estimating the risk of cancer. This is for patients who are at high risk of developing cancer, in selecting treatment, in risk of postoperative complications, in predicting oncologic outcomes, and so on and so forth. Numerous nomograms are currently available. Now, the current TNM staging system has the following problem. Here we have 3 patients, all with oral cancer, all have a T2N1 tongue cancer here, and T2N1 cancer of the upper gum and palate. They are all staged as stage 3 cancers, and their 5-year survival for stage 3 oral cancer would be 36%. But the difference is here. The first patient is a 60-year-old male. He has a 3 centimeter tongue cancer, a 2 centimeter level 1 node. He is a 20-pack year smoker. He has diabetes, coronary artery disease. None of these factors enter into the staging system. The second patient is a young female, non-smoker, and otherwise healthy. And the third patient is a 40-year-old male with also a non-smoker, but takes alcohol and has diabetes and coronary artery disease. Let us see what happens if we enter these parameters into the nomograms for these 3 patients. Because in the current staging system, we just talked about the tumor factors. We did not add host factors, we did not add response to therapy, and we did not add histomorphological features of the primary tumor. Now, in each stage of the disease, there is inherent variability. For example, in stage 3 patients, some will live long, some will die very early, and others will have about a 30% survivorship. So there is a significant variability which is not considered into the stage 3 system. For example, the patient who is here has a 90% probability of survival would be given the bad news that you have stage 3 disease and a 30% survival probability. That is not accurate. So if you go back to these 3 patients and analyze them, the first patient, 60-year-old male, tongue cancer, level 2 lymph node, 20 smoking history, diabetes and coronary artery disease, all of these factors added into the nomogram, giving him a 30% probability of death at the time of initial diagnosis. So his survivorship drops from 36% to 30%. The second patient on a nomogram increases the survival probability from 36% to 65%. And this third patient, who by current staging system would be given a 36% probability, has an 80% chance of